Hello, my name is Mike Wei. I am a GI fellow at Stanford Hospital, and on behalf of my co-authors, I would like to thank GI Endoscopy for the opportunity to discuss our recent publication called Novel Rigidizing Overtube for Scope Stabilization and Loop Prevention. In this study, we presented the utility of the Neptune rigidizing overtube in assisting with colonoscopies and other endoscopic procedures, where loop management is essential. Over time, there have been different variations of overtubes used in endoscopy, such as single balloon and double balloon enteroscopy, and spiral overtube-assisted colonoscopy. There also was a first-generation mechanically stiffening overtube that is no longer widely available clinically. The Pathfinder endoscope overtube was approved by the United States Food and Drug Administration in August 2019. The overtube is 85 centimeters long and is designed to accommodate a pediatric colonoscope. If necessary, after advancing the overtube to the desired location, the pediatric colonoscope can be removed through the overtube and be exchanged for a smaller diameter upper endoscope or enteroscope if additional maneuverability or insertion depth is required. The single-use overtube is extremely flexible in its native state. When the overtube has been advanced to the desired location, application of a vacuum can stiffen the overtube up to 15 times. In our study, we examined patients who underwent endoscopic procedures utilizing the overtube at Stanford Hospital as well as Palo Alto Veterans Affairs between May 2019 and February 2020. The overtube was used for prior incomplete colonoscopy, procedures requiring stable position, such as large polyp removal, or when deep scope insertion was needed, such as to reach a hepaticojejunostomy. The overtube was also used as a rescue device during routine colonoscopy if the cecum could not be reached. We had a total of 29 patients who received procedures involving the rigidizing overtube. 18 patients were male, and the median age was 66. One patient received an upper endoscopy, 24 received colonoscopy, and 4 received enteroscopy. The indication for use of the overtube included incomplete colonoscopy for 12 patients, going for extended insertion depth for 6, and scope stabilization for 11 patients. We found that the rigidizing overtube provided significantly more ease in performing difficult colonoscopies, and among the 12 cases in which the indication for overtube use was for incomplete colonoscopy, the median cecal time was just 6 minutes. The overtube also allowed for deep insertion, and in one case we were able to attempt altered anatomy ERCP and was able to easily reach a hepaticojejunostomy with the use of the overtube. We also found that increased ease with managing loops and greater stability allowed for difficult procedures such as endoscopic submucosal dissection. Overall, in 27 of the 29 cases, the rigidizing overtube was able to accomplish its purpose in reaching the intended distance, provide stability, or manage difficult tortuosity or looping. In only 2 patients was this not to be the case. In one case, ESD was not found to be more stable with the rigidizing overtube, and as such was performed without the overtube. In another, in an upper endoscopy, the overtube was unable to maintain the retroflex position to remove a leiomyoma at the GE junction, and as such the procedure was performed without the overtube as well. Overall, we feel that the rigidizing overtube is very helpful, and we plan to increase its use in our clinical practice in the future. We feel that the ability of the overtube to easily switch from flexible to rigid allows for further facilitation of procedures, especially in difficult colonoscopies. Our experience suggests that for colonoscopies, the rigidizing overtube can facilitate efficient completion of difficult colonoscopies in a variety of clinical scenarios. The ability to exchange a pediatric colonoscope for a longer enteroscope on demand is particularly appealing in cases where further attempts to advance the colonoscope appears to be futile. Beyond colonoscopy, we also feel that difficult enteroscopy and upper endoscopy can be facilitated with the use of the rigidizing overtube. However, we do advise caution with the use of the overtube in patients who have undergone prior abdominal surgery, especially in those who have had a history of extensive surgeries who may be at risk of traumatic injury due to adhesions. While we did include several patients who have had previously undergone major abdominal surgery, none of these patients were known to have extensive adhesions. While more studies are needed to demonstrate the utility and application of the rigidizing overtube, in the first case series published to date, we find the rigidizing overtube to be a helpful tool that can assist in colonoscopy and other endoscopic procedures. Thank you.